Hello, my name is Mayerly Castillo, and I will be going over the access to diabetic care in rural Mexico. Within this presentation, we'll be going over the background, research question, addressing the research question, timeline, and ethics. So within Mexico, the current population is 130 million individuals, with 20% of the population living in rural areas. Within rural areas, it primarily has older adults and handy workers as their main population. So handy workers within Mexico, 14% live with diabetes, and this population is primarily older adults. 41%, 41.8% of those who are uninsured do not have clinical supervision for managing their diabetes. This is overall important as the over 86% of the population has some form of health insurance in Mexico. So this can be in the Instituto Mexicano de Seguro Social. So this is similar to the United States Social Security Services for older adults, Seguridad y Servicios Sociales de los Trabajadores de Estado. So this is typically for individuals who do work within the country, are able to have this health insurance, as well as the most popular, as said in the name, Seguro Popular, is a health insurance that is more generalizable for everyday individuals for their care. Additionally, in these are governmental health insurance. Individuals can have their own private health insurance. So those who are insured, 65.8% of diabetic older adults do have some form of health insurance. They typically have IMSS as their health insurance provider. This is vastly important as individuals, as there is a high level of older adults who are insured, there is still a large portion of those who are uninsured, and this can result in majority of them utilizing self-medication for their diabetes, as the uninsured groups do have higher rates of this with 22.7%. Additionally, for those who are living in rural areas, 75.9 are uninsured and do have low access to health care services. So this could be a reflection of a disparity in providing health insurance as well as the access to it, as typically there's lower rates of providers within rural areas. Thus, there has been an initiative to bring in more international healthcare providers, typically from Cuba, to these areas in order to reduce the burden of uninsured and low access. So some of the downfalls with those for diabetic care with health insurance is that it only covers direct costs and not diabetes related complications. Typically for individuals, they are able to be provided coverage for inpatient, outpatient, as well as medication. However, if you are looking for diabetic related complication assessments, so for for kidneys, so renal, foot, and optometry assistance, those are typically out of pocket. And for individuals who have IMSS health insurance, so older adults, it is a higher out of pocket cost for services related to diabetic care. Additionally, 94.1% of diabetic patients do receive medical treatment. Although this medical treatment is typically in the form of medication, only approximately 30% have the understanding of importance of lifestyle modifications. So, although there is medication being provided to combat that, there is no long-term assistance in order to reduce risk or change their lifestyles in order to improve their diabetic outcomes. Additionally, there is a significantly lower rate in preventative diabetic services in rural areas compared to urban areas, regardless of health insurance status. This is how I mentioned prior to, with lack of access to providers in the areas. Thus, there's been more initiatives to bring external personnel to areas. In regards to hypothesis, research aims, and primary secretary objectives, within the study, we will be researching to what extent does the cost of diabetic care influence the utilization of services amongst older adults living in rural Mexico. The hypothesis is the higher the cost of diabetic care will have a negative association with the utilization of services among older adults living in rural Mexico. So our research aims is to identify financial barriers to accessing diabetic care and identify methods of and understanding of diabetes and care within older adults and in rural Mexico. Objectives is to assess financial, physical, and social factors that impact diabetic care in rural Mexico and increase knowledge of older adults, health literacy, and methods of diabetic management. So for our research design and methods, the variables that we'll be looking at are observational. So we're primarily looking at total cost of diabetic care, direct, which is medication, inpatient, outpatient services, indirect. So as I mentioned previously, diabetic related complications, so renal, optometry, as well as foot care. Additionally, additional costs, which will be transportation, as well as food modifications, lifestyle modifications, and adaptations that they may have in order to complement their diabetic care, as well as access to care. So this will be the nearest doctor, medical providers, or pharmacy, as well as an understanding of health behavior, so understanding of diagnosis and management and type of care, so Western or holistic. Additionally, our outcome that we'll be observing is utilization of diabetic care. So the design will be an exploratory mixed methods. So our qualitative data that we'll be collecting will be primarily do interviews with participants. So we'll be finding total costs primarily within the C category, as well as access to care and health behavior. This will later influence our quantitative data of total costs, A and B, and access to care. So we will be measuring total cost through quantitative economic analysis. As we're for access to care, it will be qualitative influencing GSI information. So we'll be utilizing their accounts of where a nearest provider is in order to create a quantitative measure, as well as health behavior will be qualitative. Likewise, with the outcome will be qualitative. Our study sample will be cluster sampling of 3 communities per 31 states in Mexico, and our population will be older adults with a diabetic diagnosis. Over here, we do have our work plan and timeline in the next slide. And so this will just be going over the tasks and responsibilities within the different phases of the research design and execution of the research. So some of the potential strategies, challenges, and alternative strategies is reaching the population. So this would be targeted as communicating with the local organization, key community members to gain access and communication to the demographic. So we'll primarily go during high time periods where possible caregivers may be going over, as well as family members, typically during festival time periods, in order to build the relationship with them. As well as one of the challenges is gaining trust in older adults. So we'll be creating and building the trust with the key figures in the community. So this could be the church groups, organizations, and whatnot that are active within rural communities, as well as engaging both the older adults and the caretakers in the conversation and what the purpose of the study is. Additionally, another challenge is to verify diagnosis or knowledge regarding diagnosis, as individuals may not know that they do have diabetes, or they may call diabetes another name. So this will be targeted with recruitment period. The research team will have trained professionals in diagnosing diabetes and will ask participants for their own personal medical history to understand the difference in providing the assistance or understanding if they do have a diabetes diagnosis. And then for ethical considerations, since this is seen to be somewhat similar to a helicopter research and or observation of the current management strategies, we're not actually providing intervention for them. So we do need to provide findings and methods for advocacy back to the participants in order for them to take ownership of their health and possibly gain increased levels of more access for treatments in the rural areas, as well as we need to be inconsiderate of caregivers or older adults may not want to participate in the study due to the lack of trust of their knowledge of us as the researchers and possible fear of retaliation if they do participate. Potential founders for this will be primarily the Federación Mexicana de Diabetes, which is an association for the International Diabetes Federation. So they do a lot of prevention work. regarding diabetes, and specifically within Federación Mexicana de Diabetes. They do more of health education regarding diabetes and whatnot. Additionally, the University of California does have a partnership with Mexico, so they do have a lot of research going on with AUC profession or PI in congruence with organizations and universities in Mexico to do research with them. Additionally, the World Diabetes Foundation may have possible funding abilities for this as they do a lot of advocacy regarding diabetes, as well as the National Institute of Public Health of Mexico may be very influential in understanding or evaluating their access and um, insurance rates within one of their largest populations of rural individuals. Thank you so much for listening to my presentation and have a great rest of your day.